things I've particularly taken from what we've heard from our Canadian visitors is the real importance of being absolutely clear and honest with both the public but also with health sector staff about the actual nature of the problem faced. So to be clear about the fact that yes, that there is a deficit and that how that's going to affect the health system and that actually something needs to be done. But it's not just about expressing, in a sense, the nature of the problem, but it's also, in parallel to that, setting out a vision or a strategy for how that could be tackled. And one thing I've been really struck by is the use of the word hope by our visitors, the sense that need to not just tell a story of doom and gloom, but to say, actually, things could be better as a result of all of this. It's going to be tough. We may have to close hospitals, or to use a term that I found fascinating actually, convert hospitals. So they'll become something different, still useful, still vital, still important to communities. But that at the end of that, there'll be a different approach to supporting and managing your health. And I think to really paint the picture of what services will look like for people. And I mean, that's partly narrative, but it's more than that. I think it's actually, having done the analysis, drawn together the evidence to say, these are ways in which the system isn't actually working that well at the moment. There might be variation there, we're not doing so well on patient safety, whatever it may be, but to say there is a route to making that better and to give people a sense of that.
And there's some interesting lessons, aren't there, in the process, in how this was done, because this is not bottom up, let's leave it for the market to configure this.
No, I mean, I've been very struck again from listening to the examples from Canada, that the way that they tackled both the deficit and indeed the need to transform and change healthcare provision, it was tackled at both a national, in their case a federal sort of level, but also at the provincial level as well. And I think there's a message for us there that there's a need for both some central direction, narrative about that, but backed up by some quite robust and indeed difficult measures, which might be about constraining pay, they might be about sometimes reducing the actual overall funding made available to particular health economies and so forth. But also it's about at the local level enabling different either regions or I guess in our case it'd be sort of what we tend to call health economies, to develop their own plans and vision for how services can best be provided, whether that's with converted hospital or other facilities for the future.
But someone has to manage this process. It can't be left to happen on its own.
No, and again, two messages I've taken around that. One is that you might actually have to put in place something new, perhaps separate in terms of a structure to handle this. So the example of the Health Services Restructuring Commission in Ontario, I think is very instructive there. So you might have to set up a mandated body to take a hard look at the problem, to really work carefully with stakeholders to develop these plans for the future, and then actually to take forward implementation. And the second message I take, which along with that one about robust and clear processes, is actually the politicians have to back that process and back their managers. And there was a phrase that that struck me that Mark Roshan used about politicians wearing the decisions that are made by a commission or the managers. And I think that's really important, because change of this nature, it always falls to the health service managers and the clinical leaders who work alongside them. They're the ones who actually have to make this happen, and actually at a local level have to look citizens, staff and others in the eye and say, this is what we've done, this is why we've done it and why we think it's worth it.
And these changes happened over quite short periods of time. They were quick, and it's in marked contrast to some of our reconfigurations, which can moulder on for years.
Yes, and I mean, I think that is very much to do with the fact, I mean, it was the depth and urgency of the problem that was faced in Canada. But I very much read that as actually we face a deep and urgent problem here in the English NHS at the moment in terms of the financial challenge that's faced. I guess the difference here is at the moment, I think that challenge is much better understood by people inside the health system, or certainly by the management and policy community, but much less so by the general public and arguably by a lot of health service staff.
And what about the message that a financial crisis can actually be a golden opportunity to make some fundamental changes to a health service, rather than being a threat to stability?
Yes, that is clearly possible. I mean, that's a difficult argument to make. And I think one thing we've heard from the Canadian colleagues is that actually you're not always going to win that argument, or certainly not in the short to medium term. And I think the way I would look at it is the problem is there to be tackled. And for public servants, be they managers, the policymakers, it's their job to tackle those problems, but to do that in a way that's transparent, that's robust, and that can be defended with the population and with staff. But that ultimately the respect that they may get for the way they approach these problems may be a long time in coming. And it may be several years down the line when they're able to prove that it was worth it, that health outcomes have improved, that services and patient safety have not been harmed, because those factors are clearly critical, but not to expect that people will see the approach to dealing with the crisis as necessarily a good and positive thing at the time that you're doing it.